named calage. For the moment, no questions. People are sleeping in Russia. Centering is the position of the occlusion of the mandible during ICP compared to RCP compared to centric relation. This spatial situation in the space. Where is the ICP? Stabilizing is how. What is the quality of ICP? This one, the first. Stabilizing, the calage. The centrage, the centering is where is the ICP? And the third is the guiding function, the guidage. How to access to ICP? And I proposed this classification in 1996. Stabilizing stability. It is a static analysis. Centering, compare the mandibular position in ICP to the mandibular position in centric relation. It is also static to compare two positions. And the third function is guiding functions. How to access to ICP. And with this type of classification, you can avoid to confuse stability and movement, static and cinetic. Okay, ICP, what is the quality of intercuspation? Centering, where is the ICP compared to centric relation? And guiding how to access to ICP. Now I would like to describe in detail these three functions. The stability means two things. Dental stability of each unit, dental unit. And secondly, mandibular stability, the global mandibular stability. Stability means capacity to remain constant in character or position. And there are large consensus among the clinicians that occlusal stability is imperative to almost any dental procedure. When the patient has a good ICP, a good stability in ICP, his functions are easily with muscular facilitation. The target is precise, accurate, and the reproducibility of closing movement is very good, very economic for the teeth, for the muscles, for the TMG. The stabilizing function, stabilize the teeth. Stabilize the teeth, stabilize the dental arch, no migration, or very small migration, stabilize the mandible, protect TMG, and facilitate function, swallowing, clenching, muscle play, and function. It is classical to say stability is concerning the cusp into the fossa. Okay, that is a vertical stability. But there are also another stability in horizontal direction related to the proximal contact. Dental arches are in continuity. It is an unit, and the proximal contact distributes the force to all the teeth, and so decrease the constraint on the teeth, every teeth. Mesial and distal occlusal contact, proximal contact, are very, very important for the stability of the dental arch. It is like one unit, and the continuous parabolic dental arch stabilizes the mesial pressure linked to the directions of the force of the elevator muscles. Proximal contact is an important part of the stability of the system. And perhaps you know the three lines of occlusion described by Rudolf Slavicek. The green line is the aesthetic functional guiding arch. We will discuss this with a guiding function, but nothing with a stabilized function, because it is here. No contact in ICP. The passive centric arch gives the sagittal stability, but also the active centric arch. Passive centric arch is the blue, and active centric arch is the red. Concerning the stability of the dental arch, the teeth, which are the more important, probably is the first molar. The first molar is a big teeth, the biggest teeth. Larger root, larger crown, the big cusp into the big fossa, antagonist fossa. And this first molar, this big teeth, is in place very early, 6 years old. So the position of the first molar is very, very, very important. And to keep in good health, this first molar is also very important. The first molars are the key of stabilizing function. And there are some papers which can confirm this hypothesis. And so, during treatment, you have to rebuild a very good anatomy of the teeth. But of course, we have to prevent all dental disasters like caries on these teeth. Very exposed to caries. Nothing is more important than early detection of anomalies. To realize on the first permanent molar during childhood, very high quality restorative treatment. The best service that you can give to a patient, to a young patient, is to give to him very high quality of restorative treatment on the first permanent molar. The biggest service that you can give to the patient is this type of dentistry. It is not to put a crown at 30 years. The first molar is just in front of the zygomatic process. Big support here, bone support. It is not the same in some monkeys. The biggest teeth with very good bone support. Look at the zygomatic root here in front of the first molar. I can open a very small discussion concerning the short arch. You know, full arch. Third molar is not in count. If you have dental arch 7 to 7, second molar to second molar, everything is wonderful. If you are like this, without second molars and third molars, the dental arch is reduced, but it is functional because the main point is the first molar. So it is not really a problem. The second molar is not so important to replace. It's not the same with a short arch. No molars. And it is handicapped from functional point of view. And so it is different to observe reduced arch or short arch. Not the same, different. We have to replace the first molar. We have not to replace automatically the second molar, and certainly not the third molar. Okay, for the first molar, I was discussing first molar in class 1, but what happened with the class 2 or class 3? Full class 2 and full class 3 can present a stable posterior support. Here it is a full class 2. You can see the canine, the mandibular canine behind the maxillary in full class 2. This occlusion is very stable on posterior part. Don't it is little bit, it is the same for the class 3, and it is little bit stupid to, in research concerning occlusion and TMD, to look for class 2 or for class 3 and so on, if you don't specify, if you discuss about full class 2 or partial class 2. Because a partial class 2, it is very unstable. But a full class 2 is stable from posterior support. You can have some problems on the anterior teeth, but not on the posterior support. When you look for the first molar relation, usually you are looking clinically the buccal view, and Rudolf Slavicek call it the chocolate view. It's look nice, okay, sweetie, but if you look the lingual view, it is different. And this one is a very poor post-orthodontic situation, very, very poor, because the first molar are not in occlusion, and specifically the big cusp, which is the mesial lingual cusp of the upper molar into the fossa. The big cusp into the big fossa. And this is wrong treatment. And it is one of the great interests of the digital impression, lies the immediately accessible lingual view of ICP. It is wonderful, marvelous to observe this very quickly. In 5 minutes you can have this. So it is interesting, very interesting. We can discuss also the transversal stability. And of course, it is necessary to observe the teeth not only in the sagittal view but also in the frontal view. Classically, you have three types of contact A, B, C. It is a contact described by Stuart many years ago. If you have only B and C, the biggest cusp into the larger fossa, it is okay. But if you are like this, and something, it is not, it is sometimes frequent in post-orthodontic situation because the axis of the teeth is wrong. You have contact only here. No contact, no support. The stabilizing function is very poor. And also we are looking for function, over guiding. And this one must be observed, detected before to stop the orthodontic treatment. The treatment is not finished here. It must be corrected. The error concerns the axis of the teeth. Of course, the transversal stability is given by the two sides, on right and left side. It is the same situation, and a very good transversal stability with these two key relation. Concerning the classification of the transversal posterior occlusal disorders in ICP, these different situations are probably have different potentially for pathogeny. Normal occlusion is okay. Here, height stability, it is the ideal situation, perfect, okay. Everybody can accept that the scissor bite or reversed scissor bite are very risky because the instability of the teeth and also the big no support, no occlusal support, and big risk for interference. But reversed occlusion, like this, it is stable from a static point of view. Stable. So if you control the guiding function, it is not absolutely necessary to correct this. You understand me? Not absolutely necessary to correct this. It is necessary to correct this, and also to correct this, because it is not very stable, H-to-H relation. But the difference for the H-to-H relation, it is, and the scissor bite relation, H-to-H, it is easy to correct. by orthodontic way or sometimes by prosthetic correction. But scissor bite is complex to correct, not very easy. My message is we have to classify the different situations, not put everything in the term crossbite. It is a post-orthodontic occlusion, only in France, or only in Marseille you can find this type of case. Very poor, very, very poor. The posterior support is very poor, and we have overguiding. The patient refuse a new orthodontic treatment, and we have to stabilize the situation by easy way, very easy way. Just composite resin bonding here, little bit here to optimize the function. Here, but without interference. The stabilizing function is optimized, sorry, without interference. We have to look for the easy way of treatment. So, stabilizing function is, from my point of view, very clear, very simple to understand. And after we can describe the unstable ICP, so the occlusal dysfunction of stability, with over-occlusion, infra-occlusion, loss of support, and occlusal plane disorders. Over-occlusions. The crown is too high. And you put the crown, control the insertion, and close the patient, and they are too strong. Only spot here, no contact on the natural teeth. It is over-occlusion. And I did it 43 years ago. But I have to adjust to obtain integration of the crown into the ICP of the patient. But this one is over-occlusion. And with over-occlusion, you cannot go to ICP. Over-occlusions prevent ICP. And also you have interference and prematurity and so on. It is always iatrogenic. We saw before the difference between infraocclusion and loss of posterior support. With infraocclusion, no contact in ICP. But the teeth are not so far away. And the patient can chew here. But when the patient chew here, there are no occlusal stop. And so there is a big risk for TMJ compression. In this situation, we have not a risk of TMJ compression because the patient cannot clench strongly. Low risk for compression. Concerning the loss of posterior support, you can have intermediate situation like this, or posterior loss of posterior support, or large posterior loss of posterior support. But in this case, the anterior teeth are stable. No migration, no wearing process, and so on. So the position of the vertical dimension, for example, is maintained. And it is different. We have not to confuse loss of posterior support and loss of vertical dimension. When you have a loss of posterior support, you could have rotation around the teeth with some compression on the TMG. It is a posterior rotation. With a loss of vertical dimension, the center of the rotation is on the condyle, and it is an anterior rotation. No problem for TMG. And the difference is with the loss of vertical dimension, it is a loss of posterior support, okay? Like here. With loss of anterior support. The combination of loss of posterior support and loss of anterior support is loss of vertical dimension. Sometimes with migration of the anterior teeth, and sometimes with erosive case and destruction of the anterior teeth and so on. Another type of unstable occlusion is anterior open bite. When we have not contact on the anterior teeth, it is a type of instability situation. And which need muscular compensation. It is very unstable from occlusal point of view, and the patient need to stabilize the mandibular position by the muscles, the tongue, for example, which increase the open bite. And first, this type of open bite is first a dysfunction of the stabilizing function. To evaluate the stabilizing function, you can use only clinic examination by observation, by evaluation of the contact by occlusal paper or shim stock like this here, 8 microns, the paper around 10 microns here, not 40 or 200 microns. Observe the cast to observe the lingual view or the digital impression. Only clinic. We don't need articulator to analyze the stabilizing function. I repeat, we don't need articulator to analyze the stabilizing function. The digital analysis of the ICP can be very interesting, but for the moment, I have not a very large experience, and the papers from this type of analysis for me are not very, very good for the moment. What is the minimum of stable of contact we need? Minimum, from my point of view, and it is an opinion, and this opinion is non-supported, just idea. We need to stabilize something, we need 3 points geometrically. So we can go to 4 points. The first molar. The best is contact on the big cusp, the lingual, mesiolingual cusp of the first molar, into the fossa. Key of occlusion. And after we need two other points anteriorly. It could be on the first molar, first premolar, or the best is to have on the canine, because from this point after we can have a guidance function. So with these 4 points, it is the starting point to organize the occlusion in class 1. Okay? So it was a discussion concerning the stabilizing function. And I'm not sure if there are some questions.